So I will be presenting our poster. Our poster name is Clinical and Social Determinants of Health Features of SARS-CoV-2 Infection among Black and Caribbean Hispanic patients with heart failure, the SCAN and P study. So a brief introduction. As we know, COVID-19 disproportionately affected groups of older people with cardiovascular comorbidities such as heart failure, and it also affected racial and ethnic minority groups. Most reported cases of COVID-19 are in the setting of hospitalization and severe disease, but not many studies have captured asymptomatic to mild to moderate symptomatic patients. And while disparities in outcomes based on racial differences have been reported in these groups, it's still unclear if increased outcomes in morbidity and mortality are due to higher proportion of comorbid conditions among minority patients or systemic structural barriers to care. And so our objective within the study was to determine whether differences in socioeconomic status, health literacy, and capacity to comply with, as well as aptitudes toward infection mitigation, affected the outcome among heart failure patients aged 60 or greater, infected with SARS-CoV-2 that lived in Boston and New York City. So our methods, the population of patients used in the study are patients who have heart failure and were enrolled in the SCAN and P study. SCAN and P stands for Screening for Cardiac Amyloidosis with Nuclear Imaging in Minority Populations. And so we're looking at patients that are 60 and older, have a diagnosis of heart failure, and identify as Black or African American, or additionally identify as Caribbean Hispanic, and they were enrolled in Boston and New York City. For Boston, the site is Boston Medical Center, and for New York City, we have two sites, which is Harlem Hospital and Columbia University Irving Medical Center. To verify that they had COVID-19 infection, we use nucleocapsid antibodies to SARS-CoV-2, which were measured from stored serum samples through an ELISA method. Additionally, if they had said that they had COVID-19 in the past, patients had reported that, we verified they had a positive PCR test, which is a SARS-CoV-2 polymerase chain reaction. Additionally, in SCAN and P, we do a 6-month and 12-month follow-up. We do this via phone call, and we can capture hospitalization, death, and COVID-19 infection. We're able to verify that with the patient, family, and then also verify it with medical record. If they did say they had, COVID-19 in the past, we did verify they had a positive PCR test, so that we knew that they really had COVID-19. We also determined kind of attitudes about COVID-19 with a questionnaire we developed. The questionnaire was able to test domains of knowledge of COVID-19 transmission and symptoms, perceived risk and attitudes towards COVID-19 pandemic, and their sources of information about COVID-19. So for SCAN and P, our baseline tests include demographic variables such as age, sex, smoke and alcohol use, BMI, medication, other comorbidities, insurance. Health literacy was measured through a questionnaire called Quick Assessment of Literacy in Primary Care, the newest vital sign. Additionally, we were able to capture ADI, which stands for Area Deprivation Index, using the Neighborhood Atlas. So their scores are within the United States, so we can kind of see where they live and if they're deprived of certain needs. Additionally, we do other questionnaires, such as Kansas City Cardiomyopathy Questionnaire, Trust in Healthcare Providers, Perceived Discrimination. We also have a physical capacity test that we do, a 6-minute walk test, so we can see their physical capacity. And if we look at figure 1, which is on the right over here, in total we had 103 participants enrolled in SCAN and P at the time. 66 were enrolled before we did this COVID-19 supplement. We considered 237 of them for the COVID-19 supplement. 87 of them are a retrospective cohort. And so these were patients that already had done a SCAN and P, but we had their serum still stored, so we could still do COVID-19 antibody testing and also give them the COVID-19 questionnaire if they wanted to participate. 150 were in the prospective cohort, so we were recruiting them for SCAN and P, and we also asked them if they wanted to do the COVID-19 supplement, which would include antibody testing, and it would also include completing the COVID-19 questionnaire. So this is table 1. I just kind of wanted to highlight within this table that cases were less likely to identify as Black and were less likely to smoke if they were positive for COVID-19. Additionally, cases were more likely to take ACE inhibitors if they were positive for COVID-19. Cases were more likely to utilize Medicare insurance, and no deaths were attributed to COVID-19 that were reported here. So in figure 2, we're looking at COVID positive percentage by month. So we're looking at who tested positive for COVID-19. And so as we can see, people are testing as early as January 2020. So they could possibly have COVID prior to that date that we had the serum collected from. Additionally, we can see there's no trend in this figure. Figure 3A, we're looking at lifestyle changes, so changes in their habits due to the COVID-19 pandemic, which were captured through the questionnaire. And we're seeing both if they did have COVID or didn't have COVID, they had changes to their habits, but there really is no difference between the groups. Additionally, if we're looking at living conditions, so the type of living space they had, both if they had COVID or didn't, it were similar response, so there's no difference between the groups. For figure 3C, we're looking at living conditions again. We're looking at the number of people in the residence that they live in. And so whether they were positive or negative for COVID-19, there were similar responses. So there's no difference again within these groups. Figure 3D, we're looking at living conditions again and the number of essential workers within the household. And we're seeing again similar responses. So there's no difference again, whether they had COVID-19 or not in their living conditions. So in conclusion, SARS-CoV-2 infection was common among older and minority patients that had heart failure within New York City and Boston. There were a total of 40 cases in New York City with a 37% positive percentage rate or for positive for COVID-19, and 10 in Boston, which was a 14% positive rate. Our results of positive nucleocapsid antibody tests demonstrated that SARS-CoV-2 was widely circulating through New York City well before the first cases of COVID-19 were documented in the US, which is pretty interesting. And additionally, almost half, so 44% of our New York City cohort had tested positive and been exposed to SARS-CoV-2 by the end of January 2020. 80% of our cases were found to have SARS-CoV-2 exposure based on positive serum antibodies, but they didn't have any recognized symptomatic infection. So they may have tested positive for SARS-CoV-2 antibodies, but they were not aware or would not say that they had COVID in the past. Health literacy and ADI were not associated with infection, and there was no increase in mortality or hospitalization among the affected group with SARS-CoV-2. All smokers were negative for infection to COVID-19, whether they were tested for antibodies for SARS-CoV-2 or if we asked them if they had COVID in the past, none of them had a positive PCR. So there's an unclear significance, especially to that finding with smokers. Other studies have found similar results as us, so we're not the only ones seeing this kind of phenomenon, and they're calling it like a smoker paradox. And some have suggested maybe there are biological mechanisms that could be protective with smoking. So maybe it doesn't allow for it to enter the cell with upregulation of ACE2, or if there's kind of like an anti-inflammatory mechanism with nicotine. And so they proposed a couple of different biological mechanisms of why they were not getting COVID-19. Additionally, maybe it's just a behavioral adaptation of them smoking outside and being in ventilated areas. But overall, I think we found some interesting findings, not necessarily what we expected, but I think it was still very conducive to do this study. So thank you so much for listening to my presentation.